Great. Thank you very much. And it's a real pleasure to be here. Thank you so much for inviting me, Dorina. This is a subject very close to my own heart. And obviously, infection isn't always the area that people come to dementia with. I know there's a great deal of literature about dementia as a risk factor, as a infections as risk factors for dementia, but that's not really what I'm going to talk about today. What I would like to talk about today is dementia as potentially a risk factor for infection and what the kind of infection space means, particularly for the care home population, which, as you will all be very much aware, was something that that we were very exercised with, and huge distress and suffering went on during the COVID pandemic. And I'm just going to talk a little bit about how we at UKHSA are currently thinking about differentiated and tailored approaches to health protection. And I'm going to start. Health protection, it's one of those strange terms that's very familiar in the world that I live and work in, but not so familiar. So it's seen as one of the core fields of public health, and colleagues have defined it as the protection of individuals, groups and populations through expert advice and effective collaboration to prevent and mitigate the impact of infectious disease, environmental, chemical and radiological threats. So although infectious disease is sort of writ large, pandemic preparedness and so on, we also do things like contaminated soil, radon, chemical threats, which might include something like carbon monoxide and its impacts, and also radiological. So it's quite a broad field, but it's to do with the sorts of things that we think of as outside the individual. And the key domains of health protection are communicable or infectious disease control, and emergency preparedness, resilience and response, EPRR. And obviously there's a lot of work going on in the pandemic preparedness space at the moment. And also environmental public health, which I think has an increasing overlap with care settings, where of course in care settings people don't have control over their environment in a way that they would in other spaces. So I just want to reflect a little bit on the population of care homes in England, recognising that this audience will be very much more connected with the older people's care home space. So there are nearly 15,000 care homes registered with CQC in England. 11,000 of them are for older adults and 3,500 are for younger adults. In the pandemic, the capacity tracker was set up by DHSC to keep a closer eye on our understanding of the population that were in care homes. And there are a total of around 373,000 individuals living in care homes, with a majority in older people's care homes, but a good substantial number, 30,000 odd, in younger people's care homes. And importantly, younger people are more likely to live in very small care homes, and a lot of what are effectively care homes in terms of what care is provided for younger people are actually called supported living enhanced care. So that population is actually bigger. So if you look at the number of care homes by size, there's a lot of small care homes for younger adults, and care homes for older adults tend to be much larger. And that has really important implications, because we've both got the very different vulnerabilities to infection and its consequences in younger adults than in older adult care homes. And as you'll be well aware, the estimates of the proportion of people who have some degree of dementia in care homes for older adults is something of the order of 3/4. So I got into this space of infection and dementia through some work that I did at Brighton and Sussex Medical School on scabies outbreaks, where we were very much responding to the questions that practitioners had on what is being recommended and what is happening in scabies outbreaks. There was a wealth of evidence from case reports that outbreaks in care homes for older adults were recognised very late, typically 3 months, which is a long time in the experience of somebody living in a care home for older adults. What is the experience of care home staff and residents in scabies outbreaks? And what is the best way to manage outbreaks? So though we did a range of research, and I'm not going to run through lots of it because I think I'm really quite keen to have the conversation today, but what is the best way to manage outbreaks, and why is this all so difficult? So I'll talk to you a little bit about scabies, which is a very, very interesting phenomenon. And this has really got me moving from academia into UK Health Security Agency in my social care role. So this is some research we did about scabies. Went and studied 10 outbreaks, and I think that's kind of worth, when you think getting into a care home during an outbreak and actually examining the residents, the people living with dementia in those care homes. We managed to get into 10 care homes in the southeast, in our own area, very much supported by our local practitioners, carers and staff in care homes, and also our health protection colleagues. So scabies is a condition that's produced by a little mite that burrows into your skin. It's been known about since ancient times, and it was the first identified infectious disease agent that you could see. It's mentioned in Dante's Inferno as the punishment of the moneylenders. It's been around a very long time, and it is something that it is transmitted skin to skin, predominantly prolonged skin to skin contact. But as you can see on this lady's hand with the sort of crusty looking, dandruffy looking, in some people you get a very, very proliferating response where that person might be shedding an awful lot of mites, but most of us would get itchy, mainly on our hands. And indeed, 70 years ago, this was a very common thing in primary schools, and probably the biggest thing that reduced scabies is children no longer sharing beds. So what we've seen over the last 70 years or so is a shift in who is vulnerable, and there are a lot of outbreaks in care homes for very much older adults, partly because older people are more likely to live in an institutional setting, and they need a lot of care, which will be close up and personal because it has to be to help them manage. So what we did is we got hold of care homes through our health protection colleagues that had experienced an outbreak, and we did 25 questionnaires on what was going, and we managed to go and visit 10 outbreaks and see 230 residents. And this was an extraordinary population to be visiting. The median resident age was 87 years, 3/4 female. And as you might expect from the literature that you are far much more familiar with, just over 1/4 of them had scabies as diagnosed by a consultant dermatologist plus a GP specialist who went in and examined them, having taken central proxy consent to examine, and whether that was through personal consultee or a consultee or next of kin. What we found really strikingly was that dementia was the only factor that was significantly associated with the scabies diagnosis. So amongst all the people we examined, there was a 2.5-fold increase in the likelihood of having scabies if you had dementia. It wasn't associated with that somebody already thought they had scabies at the initial visit. It wasn't associated with age. Interestingly, it wasn't associated with restricted mobility. It wasn't associated with sex or gender. continence was not a factor, and immunosuppression, which in older people would typically be perhaps diabetes, was not associated. Really strikingly, in the majority of these people, the staff said they didn't have symptoms, hadn't picked them out as might have itchy scabies, and it was largely on the hidden parts of the body, whereas the classical picture of scabies, it's on the hands, it's places that you can see. It was under the clothes. So I'm just going to stop for a bit and just really, I'd be very interested to explore what you think is going on here. And I'm going to take my slides down, if you would, and just have a bit of a discussion. So why might we go into care homes and we've got more people, you're far more likely to have scabies if you've got dementia, and the staff think that you're asymptomatic and it's under your skin. What is it that you all know about dementia that would offer itself as explanations? Because this hasn't been sort of fully, worked through yet. I don't know if people want to write in the chat. How's this conference? And what time do I need to finish, Darina? Just tell me.
So it's okay. We have plenty of time. It's probably 10 minutes for questions.
Okay.
So I
have a few more slides, but I only couple more. But I thought it's always good to have a bit of a discussion in these events.
Sure. So I think that links well also with our previous talk from Amani, who was looking at hallucination in people with dementia in care homes. And we also discuss a number of issues about staff training in recognizing different aspects. So here, let's try to unpack this as well. How well do you think care home staff are equipped to identify the early signs of scabies or different types of infection? People are just saying self-neglect. Is there more tactile interaction with people living with dementia in care homes? Individuals with dementia might require more hands-on support from staff, such as help with dressing, increasing the risk of contagion. Would you like to comment on this points coming up?
Yeah, I think these are really good points. So I think do people still use the phrase "walking with intent"? There's certainly quite a lot of where people do have very different patterns of contact for different reasons than, for example, somebody who might have serious mobility issues and continence needs. And it was quite striking that a lot of need for hands-on physical care didn't seem to correlate. Self-neglect. Now that's interesting. One. This is, of course, in a care home setting. It's interesting to think about self-neglect. If you're itching and you have dementia, what might you do, and what might you not do that somebody who doesn't have cognitive impairment, lack of attention to communication, verbal and non-verbal. You may not be able to say you're itching, and you may no longer be able to realize that itching, what is itching? It is a distressing experience, but to articulate it as itching might be something you can no longer do. So I think there are good reasons to think that people with dementia may have more and different contact, regardless of the degree of need for personal activities of daily living care, which is what sort of primarily we think of personal care for. May not feel the sensation. Yeah, possibly. I don't know. I'd be interested to know what other people say about that. What is the evidence on the neurology of people with scabies, given that this would be central rather than peripheral neuropathy? Any thoughts? And do feel free to talk out loud.
I guess it's also the stages of comorbidities they are. So on many occasions, people with dementia, they are still quite well in terms of functionality and sensations. But obviously, if they have comorbidities such as diabetes and so on, then it's a different picture altogether.
Yeah.
You mentioned that the care homes in Southeast are quite well supported by local health protection, which I kind of learned from the project we had together. But can you share a more specific example of a coordinated outbreak response in a care home that helped contain the spread of infections such as scabies or, let's say, COVID or another communicable disease?
Can you hear me?
Yeah,
Yeah.
we can.
So typically, interestingly, for scabies, I think you would often find that a care home had been uncertain as to whether this was scabies. Perhaps they had a GP in a few times, maybe somebody had been treated with cream, then somebody else had got symptoms. At some point, it would reach the threshold of asking the health protection team to give advice on how to manage it. And indeed, there is now, largely through our research, there is some national guidance being published that sort of draws on that body of evidence. And they would, the health protection team, which belongs to UKHSA, would have had a lot of experience of giving advice in different sorts of outbreak, anything from measles through to TB and so on. So they would then give advice, refer to national guidance. In some circumstances, it might be possible to get a dermatologist in to have a look, but that can be quite a difficult thing to achieve. I think the other points here, and I think, again, health protection practitioners would be very aware of this. Dorcas has said, and Helen has made really interesting points about, and Elizabeth, about older people have different symptoms and they manifest their symptoms differently, let alone people with who are living with dementia. So scratching might be interpreted as different things. The symptoms might be a typical. If you ask a doctor, they will typically think that scabies manifests on the hands and feet, on the hands particularly, and this is not the case in care home populations. So, and I have to say, I got into this because my health protection colleagues were finding it so difficult. There wasn't really literature. The last PhD on scabies in the UK at that time was in the 1920s, so it's been a very neglected issue. So I will offer up to you what I thought, the sort of general areas that I'm sort of thinking in terms of. So is it being recognised? Absolutely, points that you made. Symptoms, recognition of symptoms, do they differ? Ability to communicate symptoms, and patterns of contact and intensity of needs. And we'll all recall it during the pandemic that it became increasingly recognised, and this is true for lots of illnesses, that older people in general, and also people with who are living with dementia in particular, may well have different patterns of symptoms. And from my days doing geriatric medicine, it's certainly the case that people can get very ill very differently, and in a way that can be hard to recognise how ill they are compared to younger adults. So scabies is a particularly difficult form of outbreak because it goes on for a very long time. There is no one test. Even in our study where we had a consultant dermatologist and a specialist GP, we had a lot of people classified as probable or and not definitely. So I think a really key thing, and this is sort of where I want to sort of end on in UKHSA, we're very much thinking, how can we mitigate not only the outbreaks themselves, but the adverse impacts of outbreaks? So one thing I want to draw your attention to, and I do encourage you to share, we've published some guidance on supporting safer visiting in care homes, recognising the DHSC consultation on how should visiting be managed, on the right to be visited, on the right to go out. We've published some guidance which is about keeping visiting going during outbreaks, and that feels really important. It is perhaps particularly important to people living with dementia, but I think we can all recognise it's really important to everybody. And also, again, in the Chief Medical Officer's report, which I've linked to here on the pandemic, out on the COVID pandemic, there's a chapter on care homes. Dementia is and has been well shown to be a risk factor for acquiring infection in a number of residential settings, and for and dementia is, of course, one of the reasons many people who could otherwise manage at home do go into care. So we're very much trying to work on bringing these wider aspects into our work, bringing measures of wellbeing and impacts that are suitable for these populations into the health protection space. So many of you will be familiar with the Adult Social Care Outcomes Toolkit, which recognises that social care is not a health setting, but there are dementia-specific, learning disability-specific metrics that we need to take into account in our recommending interventions, taking into account that both the risk and the negative outcomes might be different in different populations. And also, Dorina and her colleagues have done some fantastic work for us, thinking about what the communication needs might be for people living with dementia and those caring for them. So lots to do in this space, but hopefully you can see the kind of ways that we're thinking, and would be really keen to sort of connect with people in this community to sort of continue our thought and think in the kind of real experience of these particularly vulnerable populations in the health protection work that we do. So I shall stop there